I'm most interested in how AI can make every single interaction between the patient and the healthcare system and the doctor and the healthcare system just a little bit smoother, a little bit better.
Hello and welcome to Pulse Amplify, where we sit down with the leaders and change makers shaping the future of health. Proudly brought to you by Pulse IT News. I'm your host, Louise Schaper.
And I'm your other host, George Margellis.
Our guest today is Dr NT Cheung, one of the pioneers of digital health in Hong Kong and internationally. NT has spent 3 decades doing something almost nobody else in digital health can claim, building a national-scale clinical record system from genuinely a blank page and then keeping it running and relevant for 30 years. So for more than 3 decades, NT has helped lead the Hong Kong Hospital Authority's extraordinary digital journey from an almost complete technology greenfield in the early 1990s to one of the world's largest integrated longitudinal electronic patient record systems, which supports care across Hong Kong's public hospitals and clinics. Today, as healthcare embarks on another enormous transformation, this time driven by AI, we wanted to ask NT what lessons we should carry forward, what might be fundamentally different, and what Hong Kong and mainland China can teach the rest of us about the future of healthcare. NT, it is so great to have you here in the Pulse studio. Welcome.
Thanks for the welcome, Louise. I'm really happy to be on the show.
Great to have you here, NT.
NT, you joined the Hospital Authority in 1993, I believe, so 2 years after it was created, and you've described what you inherited as a real greenfield site. So can you take us back there? What did a hospital actually look like in terms of their information before any of this existed? And what was the problem that you were originally trying to solve?
Yeah, well, I grew up in Australia. I did my medical studies there. I was in hospitals in Australia in the early 80s, and I came to Hong Kong in the 90s. And the information landscape was probably similar to when I was studying medicine. So when I say greenfields, what I was talking about was there's, pretty much zero use of computers at the clinical level. We inherited everything from the British colonial days. And what the hospital authority was formed to do was to put in professional management and modernize the whole system. And so one of the things that they thought back then was that, well, IT has got to be part of any modernization. So that's why I came in, because they saw the need. Now, I have to be honest, nobody knew what that meant. Okay. But we did know it was something that we wanted to get to. So I came here to start that as a person with a medical background and an IT background.
That must have been so exciting. What personally motivated you, NT, to, you know what I'm going to do? I'm going to go over to Hong Kong and go on this journey.
I'd always been really interested in computers. I mean, this is back in the Apple II days. We're talking about the 70s and 80s. And when I studied medicine, I was in this completely manual world. And I was thinking, wow, everyone else is starting to learn to use computers for what they're doing. And us in the medical field, basically zero. And I just thought there's so much potential here. And then I started reading the informatics literature. Most of that was coming from the US back in those days, and going, oh, there's all this stuff happening across the pond. And I think I want to get into that. And I actually met some people in Australia who were starting their own company to build medical record systems and all that sort of stuff. So while I was studying medicine, I was working full time as a developer, actually. So that was an interesting time in my life. Self-taught, right? And then I realized there's actually more to computing than just self-taught on a PC type of stuff. So I went and got myself an actual degree. And then this opportunity came up in the Hong Kong Hospital Authority. And I thought, oh, that sounds interesting. So I came over.
George, did you meet NT in those days in Sydney?
I don't think we did in those days, because what university were you at, NT?
I was at Sydney.
Yeah, I was at New South. And there the twain shall meet back in those days. but yeah, look, I remember that time fondly. I bought myself a ZX81 back in the early 80s to learn how to use a computer, and went through the whole Apple II, Commodore, finally worked our way up to an IBM PC. And it was a tough time. The hospitals were totally paper-driven back in those days, with the exception maybe of the billing systems and the pathology billing systems. So everything else was paper-driven. And a clinician with an IT background, yet alone an IT degree, would have been as rare as hen's teeth. So I can understand what drew you over to Hong Kong. I remember in my early days, clinicians used to look upon me and say, why are you playing with a computer? That's not a doctor's job. That's a technician's job. And simple things like having networks in hospital. Forget Wi-Fi network, just having blue cable between computers. I had to get underneath the table and plug them in myself to make it to work. What was it like in Hong Kong? Did they provide you with an infrastructure to get started, or did you have to start from scratch?
Well, yeah, I was a real rarity. And people actually remember me because they remember me as the guy who had a medical degree but wasn't practicing, right? I was going full-time in computing. So that was quite memorable. So in some way, that was a bit of an advantage. Yeah. But I actually came in under the IT department. I didn't come in under clinical. So it was basically IT who thought, oh, yeah, we need to try and make a difference here, but we have no idea how medicine works. So they said, we need someone who has a background. And I have to be honest, they didn't really know what they were going to do with me. They just thought they needed somebody. And I was really keen because this was my vision. That's what I wanted to do, use computers to modernize healthcare. And here was this opportunity. It was a blank sheet of paper. I could take us anywhere we wanted to. Because back then, trying to even explain to people what I was doing, there was no reference point for people. So you play with computers, you're a doctor, okay, that's interesting, but
Yep.
My mother for many years rolled her eyes and went, what hospital do you work at again? What do you do? And look, there's a lesson there for obviously younger doctors because this was greenfield area and we had to design where we were going. We had to develop a pathway. And back then, most doctors had a very classical career path. You did your residency, you joined a specialty college, you did your relevant training, then you went into a hospital or you went into private practice, and that just didn't exist. In Hong Kong, you were hired by the IT department. Obviously, you rose up that department fairly quickly. So what was the process like from a career perspective of coming in as the doctor in the IT department and becoming the head of the IT department effectively?
It's one of those things that just happened over the years. So initially, of course, there was no clinical understanding in the IT department. I wasn't the only person with a clinical background. We had some people, not very many, but nursing, from coding backgrounds, maybe some people from lab backgrounds, that sort of thing. So there's a few people like that. I was the only doctor. And, in Hong Kong, the medical system is very doctor-led, right? So being a doctor actually made a huge difference. I could tell you stories about some of the weird stuff that happened. Just when people understood that, oh, I'm actually a doctor, their whole attitude changed.
Well, we have time for some weird stories.
Well, so back then, people thought it was just for hobbyists and tinkering around. And especially people who were already senior, like in medical or in management, they were actually very proud of the fact that they never had to touch a computer. They would say it in this sort of self-deprecating way, oh, no, I don't know how these things work. But you could tell that deep down they were quite proud that I don't have dirty hands with this stuff. And I leave it to lesser people. So that was this attitude that was quite prevalent, right? You had a few enthusiasts, but a lot of senior people looked quite down on this sort of thing. The other thing that I found was very difficult was this vast gulf in IT literacy back then. So I remember I would turn up to a ward, for instance, and then I would realize that a lot of those staff there had never even seen a mouse, right? They had no idea what this thing was. Then you had this other side, you had these enthusiast guys. A lot of doctors are actually very technical. They have this very engineering mindset. And so they would be building their own machine and all that sort of stuff. So you'd have this vast gulf between people. And then you had some people who really looked down on it, some people who really wanted to move forward with it. So there was this huge gulf, and you were trying to find a way between these various camps of people. And none of them really had a clear idea of what it was we needed to move towards, because, like I said, nobody had seen it before. So when you say, how did the career develop? There was no established career. I never had an actual mentor in this field, right? Because there's nobody who knew anything about it. And we're finding our own way and building up a team in my department, and also building up a lot of people in the clinical world, the doctors, the nurses, hospital management, all that sort of thing. And so amongst that population, we're able to find people who are doing their full-time jobs, but they're willing to really spend more time to try things out, to start helping us lead the whole thing and bring other people on board. I think that was really important, that we were able to get very strong clinical leadership for what we were trying to do. And then as our footprint grew and people saw what it could do, then naturally more people would be willing to come on board.
Fast forward 30 years, and you guys ended up making a decision that most jurisdictions still don't. You built it yourself in-house and you sustained it for 30 years. I understand that Hong Kong now has ultimately one of the world's largest integrated longitudinal patient records. How did you succeed where so many large-scale health IT programs have really struggled?
Paradoxically, I would say it was really not having the budget to go and do a massive procurement project. It would have been a government procurement exercise. massive constraints, very inflexible. And I think that would have doomed us to a lot of the problems that I see elsewhere, where these things become procurement. And then, because we were doing it organically, the clinical needs were always first and foremost. We were solving healthcare problems. We weren't solving some sort of budgetary or procurement problem. And we were able to isolate ourselves from a lot of that sort of thing just by being rather small and under the radar, really. I actually remember I came to Australia. I can't remember exactly when, but a very long time ago. And people asked this question: "You're doing this yourself. Do you think Australia should do it?" And I was trying to be politic because I knew that it was difficult for you guys to go that way just because of the way things were set up. And I think I really should have tried to tell you guys, no, definitely you should do it. I mean, it's taken us years to get to where we are. And this was maybe 20 years ago. So we've been doing it for 10 years or something. And I think you want to get things done quicker, then you're not going to have the time to build up that organic base to do it yourself. But it's 20 years later, I think you definitely had enough time. And I actually think it's never too late because we were not constrained by that procurement process. We're able to take our time, find what works, change paths, a lot of pivoting, and really build something that was right for what we needed. And as time goes by, this is one of the things about healthcare is that it's a constantly changing field. We know that, but I think people in the technology field don't understand that it's not a once and done thing, right? You build something and it instantly is obsolete as your healthcare system is changing. Healthcare itself, of course, is always changing. So having that flexibility, because we own the IP, we have the people with the skills who are able to change technology to suit our needs. That's been a real difference, I think.
I remember I visited Hong Kong in 2008 and you took us through some of the hospitals. And I remember many of the Australian clinicians going that, sure, the interface may not have been as user-friendly as some of the more modern systems, but the number of things that your system did compared to ours, the fact that we didn't have to log out of a system and log into another system to do multiple things was part of it. The EMR transformation was huge. But we're now starting to go into the next transformation. We're moving away from EMRs as the tool to EMR being the data source for the AI. What do you think is different this time? Is AI change the whole thing dramatically, or is it just another digital transformation that we need to get our heads around?
That is the big question. AI is this amazing tool that allows us to have capabilities we would never have thought possible just a few years ago, right? So it's amazing. But I think it's really important to remember that it is still a tool. It's a tool which will allow us to do more stuff that would have been difficult before and get us to new areas and cover new problems. But as a tool, it's something that takes over the whole shop. We've always built our EMR as a clinical tool. It tries to make the delivery of healthcare smoother, higher quality, more accurate, less work for the clinicians. And that very strong clinician focus, I think, is something that you don't see in the commercial systems because oftentimes they're solving administrative and financial problems first and foremost before they tackle the clinical problems, almost as a side issue, really. But for us, it's always been the heart. So I would imagine for us that AI should still be just another ability on top of what we already built, but still within that framework of a system which is there to help our clinicians do a better job and help the patients achieve a better outcome, but not as something which takes over. That's one of the concerns I have, a lot of other industries. You can sort of disrupt and whatever, and it's fine, but you can't disrupt healthcare as people die. And I always think that's one of the things we need to be very cognizant of is what are we here for? It's to make people better, stay healthy, not to bring in big bucks and be whiz bang. And technology, especially in the last few years, has been about this massive thing where it's going to come over and take over everything. And I'm not even just talking about people's jobs. Healthcare is a very human process. It's labor intensive because of its very nature. You take out the people, you basically lose so much, right? And I think that's something we really need to be very aware of, that we're building systems to help people, not to get rid of people. I'm just a bit worried that a lot of the rhetoric that's floating around gets away from what we should be doing.
I'm saying for decades now that it's going to transform healthcare. We've seen big tech come in and out when they realize how complicated it is. This new breed of technical overlords seem to have this idea that AI will solve everything. So it'll be interesting to see what their experience is down the track.
Yeah, no, absolutely. This is one of the things that I've been saying for a very long time is that the tech industry has been coming in trying to transform healthcare and they've consistently failed. I've said, there's a lot of pushback from people in other industries that healthcare is the most complex industry, the most complex information environment that humans deal with. And of course, anybody from outside the healthcare industry says, no, we're in an incredibly complex industry ourselves. And sure, everybody's in a complex industry, but I still contend that healthcare has the most complex environment, socio-technical, informational environment that there exists in the world today, especially when we're talking about hospital care or integrated healthcare systems. I mean, incredibly complicated, right? And to expect to throw technology in and just fix it, that's just a pipe dream. We're nowhere near having that sort of technology. And I don't think the current generation of AI, amazing though it is, I don't think can do that either. So it really needs to keep the humans at the helm, drive this forward with those very human concerns at the heart of it.
Oh, absolutely. Time for a quick break, and when we return, we'll be talking to NT about the data opportunity available to Hong Kong with 30 years of patient data. We're also going to be looking across the border to mainland China and learning how Hong Kong has connected their health system with clinicians in China. Finally, we're going to be looking at how Hong Kong is designing systems for an ageing society. Back with more soon.
So you now have a clinical system in place that has 30 years of patient data on it, which is very rare in this world. Most places have very recent data. Two questions. One, have they maintained that data set as a potential research tool? And what sort of opportunities does having 30 years of patient data that's been accumulated through various phases of the way healthcare has been delivered, what does that provide us as an opportunity going forward?
Back in the 90s, when I was early on in this whole journey, I remember writing this thing which said that first and foremost, we're about the patient record. So in those days, I was calling it the patient record as the document which would inform care for this patient over their entire life and across all the care boundaries they would have to cross, right? And we've been through, I think, 4 major tech stack upgrades over the years, but the data itself, largely it's been preserved. So it's not just 30 years of data, it's 30 years of data which has been highly conserved in the way it's been collected and in the way it's been codified. And also, the other thing about it is that we have 40 plus hospitals, well over 100 clinics in the hospital authority, all on a single build. So that's fairly unique. Now, of course, we all know that data is the new gold. And one of the things that the model builders don't have access to, they can scrape the internet, they cannot scrape our medical records, right? So they don't have access to a data set like what we have. I don't think anybody has that. We've tried bringing in a commercial model, compared it to what we could build ourselves using our own data. And against our patient group, our own models will work better because they're trained on Hong Kong patients, as opposed to God knows where these other people are getting their data from. So it is actually a huge advantage to be able to build systems based on your own patient set to treat your own patients.
Amazing. Now, I wanted to talk about cross-border information sharing. So my understanding is that since December last year, that over 6 million residents of Hong Kong can authorise doctors in mainland China to view their Hong Kong health records. Now, most jurisdictions, including here in Australia, we can't even get 2 hospitals in the same city to share information easily. So how do you get consent, standards, trust and law to line up? And any lessons learned there about how you made that happen?
So it's early days, but I think that one of the key things is that we had already established that capability within Hong Kong itself. All of the hospital authorities have been sharing their data since 2000 or so. And then in, I think, 2013, was that when we went live with the record sharing amongst public and private sector hospitals? And the natural progression is to say, okay, a lot of people in Hong Kong are crossing the border nowadays, so there's a demand, right? We were just able to take what we'd already built up. Because it was so driven by what we'd done, it was very much a Hong Kong-led effort, that we just said, okay, we're going to use the standards that we've been using in our own e-health record sharing system. The other thing that we did was we made it dead easy for a mainland hospital to join. Technology-wise, we built everything for them. They just needed to use it, basically. Even integration was not that much. So when we're doing it within the hospital authority, because we own the whole thing, whether it's complicated or simple is not really a concern for adoption, because we're doing all that work. When we started working with the private healthcare sector in Hong Kong, that became a big issue because if it wasn't dead easy, would have been a lot harder for them to join because they'd have to invest and they have to learn so much more. So making the technology as easy as possible has been something that's been really important. And that allowed us to line up with hospitals in China very easily. And of course, you've mentioned the law and all that stuff, some of that stuff now, which is above my pay grade. A lot of this was driven by ministry to ministry level of discussion to make some of those things happen. And that, I think, is very much because everybody sees the demand. They want to make it happen, so they do it at that level. And policy, definitely policy had to line up. I was focusing more on how we actually do it technology-wise, user interface-wise, standards-wise, all that sort of stuff, privacy-wise, to just make sure that it could happen.
Amazing.
So I was in Hong Kong a couple of weeks ago for the Golden Age Foundation meeting, which is one of the leading organizations there looking at aging populations. And Hong Kong, just like Australia, has the challenge of a rapidly aging population. I think actually you guys are a few years ahead of us. So you've got 1.5 million people over the age of 65, although I still don't consider over 65 to be old now that I'm turned 65. But moving on. But yeah, that number's going to double in the next few years. And you guys have the same challenges as us. You have acute housing pressures. You've got a lot of people who moving to somewhere else they can age more efficiently. What are you doing from a healthcare perspective and from a health technology perspective to enable that aging to happen, and taking into account that aging doesn't happen inside a hospital, it happens in the community in general?
Yeah, my definition of old is always, it's a few years older than me. That's been my definition forever. So yeah, this is a huge problem. It's a problem for almost every society that we have in the world today, this aging population thing. What we're trying to do is move away from focusing on medical and talking more about elderly services, social services, integrated services, all of government approach, that sort of stuff. What is harder? How does the private sector contribute more to that? I think there's a lot of opportunity there. It's just getting the right people who are interested in developing those opportunities. I don't think the government can just keep on shouldering the entire burden. Tax base gets smaller as people get older and all that. So a focus on the less expensive aspects, the more integrated aspects in the community. I think that's what we need to do. Not to say that healthcare doesn't have room to improve. Healthcare can continue on its own trajectory, but the focus should be looking at integration and the connection point between health and elderly, or health and social. They need to integrate more. This is one of those areas where your large language model type of technology can make a huge difference, because now you can start talking across boundaries using language, unstructured things. You don't have to all speak the same technical language to cross those barriers, because the AI can do it for you. So there are some remarkable opportunities which would have been huge technical barriers in the past, which you could use models in the middle to massage things. We can do a lot more than we could in the past.
The use of technology in people's homes. So devices that facilitate communication, devices that facilitate cognitive stimulation. And what I found interesting was a lot of the older people in Hong Kong were happy to try these devices in their homes. Do you find that consumer adoption is improving?
Maybe Asians are fairly tech accepting. Largely, I find that people in Hong Kong are willing. I don't think that's the main issue. It's how it's built so that it helps them. I think that's really important.
Now, NT, this could be an entire podcast on its own, so I'm a little nervous asking the next question, but I'm going to ask it and see if there's a contained answer. So you have a distinct vantage point from Hong Kong on digital health developments in mainland China. So what are the highlights? What's happening there that the rest of the world is underestimating or simply not seeing?
Well, first of all, I am in no way a China expert. I've spent my career in Hong Kong. We're right next to China, but for most of the years I've been here, it's been a very distinct place in almost all aspects. And really the barrier has come down a lot ever since COVID. We're all learning an awful lot very quickly about how China works, but by no means am I an expert. My first comment is that I would never underestimate the ability of the mainland to develop stuff, to move forward with just amazing stuff. They can apply resources and they have the brain power, and they also have the willingness to try things. They're less constrained and they're willing to try things out, and then they're also willing to cut them off if they think they're a problem, right? Which means they can move forward very quickly and the good stuff gets to come through. And so it's happened very quickly. Now, the other thing is because of the crazy scale of China, a lot more things become economically viable. You get the scales of economy, which, Hong Kong's 7 million, even Australia is not that big a place, right? So you have this difficulty where things are just not economic when you don't have that scale, but China has that scale, so they can do stuff which other people just simply cannot even try. China's very acutely aware of their own demographic problem with the aftermath of the one-child policy and the aging population is definitely something that China is very focused on. They have the ability in the mainland to really focus resources on key problems. And so they're going to be spending a lot of energy looking at that. And that's something that we can all learn from. The other thing that I would say, though, is that as we learn from what they're doing in China, I think we need to be very aware of the context in which things are developed. I mean, they have a very different social and political and economic system. So what works there may or may not work for where we are, but we should definitely take note and see and be inspired more than to try and just bring it over and try and copy it. Now, the reverse question is that China is very keen to export what it's doing. That this is where Hong Kong comes in, because Hong Kong provides a bridge between China and the rest of the world. Hong Kong's always been very international in outlook just by nature. And so we understand the West. We're now increasingly understanding China, so that we can see the sort of tech and the things that they're building in China. How could they apply to the rest of the world? And maybe how can we guide the developments in China so that they are more naturally suited to what everybody else needs in the world? So I think there's roles on both sides for this.
Looking back over 30 years, that you've met a lot of people, you've had international experience. What are the conversations in digital health that we're just not having yet? Are we still focusing too much on managing data and not about managing patients? And in particular for young up-and-coming doctors like we were 30, 40 years ago to get into this field, what do they need to be thinking about as far as what digital health will look like?
Yeah, I still feel that there's a little bit of a, wow, isn't this cool factor when people who are into it, right? The people who are into it, they're enamored by the new and the flashy and all that stuff. And I think that's actually a detriment. Over the years, I've worked with a lot of clinicians. I've actually valued the guys who come in when I first meet them who are very skeptical. I've always valued them far more than the ones who come in and they're really keen. Because the ones who are really keen, like anything that's flash, they're into. They'll like it. They'll say, oh, yeah, that sounds great. People who are skeptical are the ones who put your ideas to the fire, and they'll tell you what just simply won't work. One of the interesting things about healthcare is that you can't force it, right? If you build this thing out and then you try and roll it out to somebody, if it doesn't work for them, they're not going to use it, right? They're just simply not. You can try and force it for a while, but ultimately it's going to fail. So I think it's very good to keep in mind that we're building this for the whole audience of patients, the whole audience of clinicians, and make sure this actually speaks to what they need and supports what they need to do day to day. So that to me is a key thing. One of the things that I've tried to do is to just say that the digital aspect, the IT aspect, is not a separate thing from healthcare. It's part of how healthcare should be delivered now. As we're building healthcare systems and improving what we're doing in healthcare, we should just use digital as a tool, just as a natural tool. It's not something that you tack on at the end. When you're thinking about something, you think about it with a digital perspective. And now, the new thing is we just think about it with an AI perspective. This ability for non-tech people, for your normal clinical people who are driving forward to healthcare, for them to have that ability. And I think that's the sort of thing that we should be trying to build out in the broader community. 30 years of spending time in the hospital authority, integrated with management, sitting there at the highest level discussions, has allowed that to develop to a degree in Hong Kong. There's still a lot more work to do in that sense. But a lot of other places, it's still very much viewed as a separate thing, as an add-on. One day, we won't have the word digital health anymore, because what do you mean digital?
Banking?
It's like you don't have banking anymore if you weren't digital. Healthcare is a ways away from that, but that's where I want to be. Yeah, I look forward to that day.
Yes. I would have thought by now we'd be there. Considering you're at a slightly different phase of your career than me, do you think we're going to get rid of the digital soon?
I don't know. It'll happen, I think, eventually. But these things just take a long time, it seems. I mean, so, George talking about we've spent whole careers in this from when we were young guys to now. That's a long time already, and it's still nowhere near where we think it should be. People still don't really understand what we're doing. There's still a bit of work to do there. I think that'll happen. It just might just take longer than we'd hoped.
My background's Greek, so medicine goes back 2,500 years. China has exactly the same thing. You have medicine going back 2,500 years. These revolutionary changes really are just building on a multi-millennia foundation. And like you pointed out, it's all about improving clinical care, not capturing more data for data's sake.
We've seen a lot of places where healthcare IT is being driven by financial and by administrative needs, and that's just the wrong focus. But as we move forward, I think more and more people will insist that, no, this is how I'm doing my clinical work. I expect it to be much smoother. I expect it not to have all these manual frictions, because everywhere else in my life, it's so easy. I just bring up my phone, right? And then why are you forcing me to do all this stuff with these antiquated systems? I think that pressure is going to be unstoppable, as almost everybody who's now working at a senior level has that same feeling. I don't think we've quite got there yet, because people who are retiring now are my age. And when I went through medicine, I'm pretty sure I was the only person who used a computer. There's still a lot of people who are working today in senior positions who don't have that digital native sense, but it'll happen.
That was our mightiest tool we had as a graduating doctor.
Oh, NT, you are an absolute delight. Thank you so much for sharing all your wisdom with us. Well, not all your wisdom, some of your wisdom with us on the pod today. It's been great having you on the show. Really appreciate it.
No, it's been fun. Thanks for having me.
Thank you for listening to Pulse, brought to you by Pulse IT News. Pulse is produced by me, Louise Shaper, with audio engineering by Ivan Jurek of Octopod Productions. Thanks to Emily Mara, co-founder and publisher of Pulse IT News, for all of her support. Big thanks to you, everyone, for listening. We have a growing audience across the globe, so make sure you tell a friend about us. The more people that subscribe, follow and rate us means that more people can find this podcast that we love bringing to you every week. And don't forget, you can visit pulseit.news to sign up for the e-newsletter and explore Pulse IT's massive digital archive. Send any feedback or topic suggestions to George and I at pulseit@pulseit.news. Always love to hear from you guys. See ya.